in the brain, or what the inside skull structure inside the skull look like. And this is one of the first image of ultrasound which came up. Next. So I was introduced to this fascinating field by none other than my mentor, Dr. Mukund Joshi, who is rightly known as the father of ultrasound in India, and he brought me into this wonderful field. He was at the Sion Hospital LTMC, where I was a lecturer. Next. So when we started off, we had this wonderful machine, and this was a static scanner, and it used to take 1 hour per patient. Now we know that today in 1 hour we can do so many patients, and we had this ghastly chair here. This chair was used for transvaginal and transrectal ultrasound. So it was like an electric chair. I mean, it is a dreadful thought even to sit on that chair. Next one. And this is one of the first machines where we worked on, where we had what is known as I have the pointer worked at this, where we had a linear scanner, and this is one of the first machines which we had in Sion and subsequently in my own private setup. Next one. But things evolved very rapidly, and from 70s to 80s to before we turned into this present century. Next one. We already had machines which were very compact and which could do almost a lot of things, and of course they even responded to your commands. So you tell the machine switch on, switch off the color Doppler, whatever, the machine started listening. And this happened almost 25 years back. But now of course things have changed even more, as we'll see later on. Next one. And then these are the various transducers we use depending upon what we want to do, whether we want to do small parts, musculoskeletal ultrasound for rheumatology, abdomen, gynec, Dr. Mirchandani, transvaginal, transrectal probes, etc. So depending upon the use, we have different probes, we have different frequencies, etc. Next one. So what are the advantages of ultrasound, especially as compared to other imaging modalities? One, there is no ionizing radiation, unlike CT scan, where we use radiation, and therefore it is the apt sort of a technique to look at pregnant women as well as children. It is safe, non-invasive, it's real time. No other imaging modality, whether it is CT or MR or X-rays, are real time, and I will show you advantages of that. And then of course, we don't use iodinated contrast, which can have its own nephrotoxicity. It's very cost effective, versatile, available, follow-ups are very easy and portable. So that's an NICU, that's a very small kit, but we have taken the machine there that's a Just-Look NICU to look at that kit. So it's a portable, portability is a big advantage. Next one. So when we say versatile, this is the advantage. For example, we have a patient who has extensive mets, who has multiple lymph nodes in the abdomen. Next please. Ultrasound also showed the same, but CT did not tell us what the problem is, because they went up to a certain level and they stopped. But when it comes to ultrasound, we can just change the probe and go from one area to the other. So this is a male patient. So what do you think I did? I'm going to ask questions just like he did. Multiple retropedal nodes, male patient. So I switched the probes into a high frequency probe and looked at his testes. Next please. And what we saw is a seminoma. So what was missed on CT, simply because they had just looked at the abdomen and stopped there. We could easily just switch off, change the probe and look at his testes and come to a right diagnosis of where the metastases are coming from. So that is the versatility of this machine. Next time. And real time. So I don't know whether you can appreciate, but this is a patient who came with pain in the left hemiscrotum and spermatic inguinal area. What we see are sonolucent or black areas. And can you see those white things dancing there? What are these? Any idea? So these are filarial worms. Okay? So these are filarial worms, and this patient has filariasis, and these are light worms. So, so this, why are we seeing them? Because it's real time. So as things happen, we are actually seeing movements, and we are seeing the worms moving inside the spermatic cord in the dilated lymphatics. Next one. Look at this. This is a child with vague abdominal pain. What do you think this is? This is the intestine of the patient. This is the mucosa of the intestine. This is your roundworm, your friend. And in the center of the roundworm is the intestine of the roundworm. And in the center of that intestinal lumen of the roundworm, we can see the food particles which are in the intestine of the roundworm, which are eaten by the patient. So that is the level of resolution which we have. We have intestine, we are seeing the layers of intestine, inside that is our roundworm, the friend. You have any other pointer? And inside that roundworm, we have its intestine with the food particle. And remember, look at the date, it is 2005. And just imagine what must have happened to the resolution of the machine in the last 20 years or so. Okay. The next one, yeah. So, as I said, it's very versatile. So, patient with acute abdomen, find out whether there's a CBD calculus, find out whether there's pancreatitis, find out whether there's a cholecystitis. Oh, it's working. Oh, that's great. Fantastic. So, whether it's a CBD calculus, whether it's a pancreatitis, whether it's a cholecystitis, next. And then, of course, acute abdomen, go to the right iliac fossa, that's acute appendicitis. Here you can see a perforation of appendix. You can see that perforation, and from that perforated appendix, we can see fluid coming into the right iliac fossa. And look at this. This is an appendix, and within the appendix, can you see some, again, linear echoes which are moving? Can you appreciate that? So these are other parasites, trichura, rootworms. So within this appendix, this child has these worms which are moving. That is the sort of resolution which we are talking about. Next one. And then a pain in the right iliac fossa, whether it's a ureteric calculus, whether it's something like an ovarian torsion, or whether it's an ectopic, we can just change the probe and find out. So here, calculus we do a transabdominal probe, and for something like an ectopic or ovarian torsion, we do a transvaginal probe. So depending upon the situation, we go on changing the probes. Next one. And then pediatrics, where you do not want to give X-rays, you do not want to expose the child to radiation, we will suspect hypertrophic pulmonary stenosis, we might do something for the hip joint, CDH, or maybe something in the lung. Again, just switch probes, and it's absolutely safe in the pediatric age group. Next one. And then fevers, like patient has a fever, unknown, we don't know what it is, PUO, there are some hidden abscesses. Here we have an adrenal abscess, here we have a prosthetic abscess, which is very often missed in clinical practice. This child has dengue because there is classical edema of the gallbladder wall, adrenal hemorrhage, and a small amount of fluid. So it's a very versatile, you can just go all over the abdomen, chest, and find out what's wrong and what is the cause of the symptoms. Next one. And then gynec again. Now in gynec and obstetrics, we cannot do anything without ultrasound. It is like the finger of the gynecologist, transvaginal probe. So not only picking up ovarian masses, but we can characterize them. It's a simple cyst, hemorrhagic cyst, endometriosis, dermoid, etc. Next one. And the most important is pregnancy, of course. Right from diagnosis of pregnancy to finding out growth disorders, to finding out anomalies, to find out if there are chromosomal or genetic problems, to deciding what is the time of delivery. Not only that, I'll show you at the end, correcting some of the things which are wrong with the fetus we can do under ultrasound guidance. So we have two scans which are important. One is what is known as an NT scan, which is done at 12 weeks, and then we have to do an anomaly scan at 18 to 20 weeks. Next one. So we can pick up anomalies nowadays in the first trimester. That is, at 10 weeks or 12 weeks, we can pick up if something is grossly wrong, either with the heart or with the skeletal system, or for that matter, even in the GI system. So we are picking up more and more anomalies, especially brain anomalies, heart anomalies, now in the first trimester, as early as 11 to 12 weeks of gestation. Next one. And then of course we pick up more and more anomalies as we come to the second trimester. Almost all systems nowadays, we can pick up some anomaly either directly or by some indirect signs. And then of course we can counsel the patient accordingly. Next one. And then came this wonderful technique. Can I have a, yeah, okay. Then some years back, another technique was introduced which is known as Doppler. So anyone knows what is a Doppler effect? Yeah. So it's a change of frequency of sound waves caused by the motion of the source or the observer. So here, for example, this police van is giving out a siren. This girl is standing here, this boy is standing here. The siren is at a particular pitch of frequency, but this girl feels that it is decreasing. Why? Because the sound is going away from her. Whereas this person where the car is coming towards him, he perceives that the pitch is increasing. Actually the sound of the pitch is the same. So they perceive it is increasing or decreasing, and that is because of the Doppler effect. So we use Doppler effect to see blood flow in the body, in various vessels, and we can find out everything about the blood flow. Next one. Whether there is flow, whether there is no flow, what is the velocity, what is the direction, what are the characteristics of the blood flow, etc. So we use it in peripheral vessels. For example, here patient has legs pain, there is a popliteal artery thrombus, and this is a spectral waveform again which tells us that there is a pre-occlusion. Next one. And then this is patient who has got a TIA. So we can see there is a large carotid plaque there, which is causing stenosis. So we can find out how much is the grade of stenosis. And number 2 is what sort of a plaque it is, whether it is a soft or a hard plaque. Next one. And then patients coming with swelling in the leg. This has an acute DVT. Here you can see that the artery is showing flow and the vein is totally blocked with a large thrombus. Next one. And now we can see very small vessels. For example, small vessels within the kidney right up to the capsule. And this is a patient who has got a large intestinal polyp, and we can see the blood flow even in the polyp with the pedicle. This is in the intestine. So we can see blood flow even in very small vessels. Next one. And then we have higher frequency probes. These are used for what are known as small parts. That means, for example, looking at orbits, that's a retinal detachment, that's a thyroid nodule. Next one. And then of course we have intraoral probes to look at salivary gland, to look at the floor of the mouth, etc. Next one. And then of course these high frequency probes are again used to see malignancies, for example characterizing breast lesions, whether it's a benign lesion or a malignant one. And again this movie is not playing, but these are again filarial worms within the breast lymphatics. Next one. And we can give a clinician the idea of where exactly is the lesion in relation to the rest of the breast. And this is known as panoramic imaging. So we give a complete picture of the organ and tell the clinician exactly where the region is. Next one. And we use it extensively in musculoskeletal system and in rheumatology nowadays, not only to diagnose but also to sort of do ultrasound guided treatments, for example steroid injections, etc. So once upon a time we thought that we will not be able to look at bones because bones is an enemy of ultrasound, but now we are doing extensive musculoskeletal ultrasound almost of all joints. Number 2, we thought air is an enemy of ultrasound, so we won't be able to see bowel. Next. But now we are able to look not only at bowel but also pick up a lot of pathologies within the bowel. For example, here we have a patient who has got a diverticulitis. Next one. And the machines are becoming compact, smaller and smaller. Next one. And of course, so this is the old time physician who would go into the ward with a stethoscope. So instead of a stethoscope, why not just take an ultrasound machine to the ward? If the patient has a murmur, put the probe there and you know what sort of a heart disease is. If you are suspecting pleural effusion, just put the probe there and find out whether there is a pleural effusion or no. Next one. So when you take the machine to the bedside of the patient, this is now typically known as a point of care ultrasound. Next one. So for example, during the COVID era, we used portable ultrasound machines everywhere. I work in Jasra Hospital and I also go to a couple of teaching institutes, but we use portable ultrasound everywhere to pick up if there is any lung problem. Next one. And the machines are becoming even so small that today I've got one in my watch as well. Okay, next one. But ye dil mange more. We are not happy, right? We should not be happy. We should be more. We should look for more and more things. So a few years back, 3 new things were introduced in the field of ultrasound. Next one. One is what is known as volumetric ultrasound. Number 2, what is known as ultrasound contrast. So these are micro bubbles. We'll talk about this. And the third is elastography. So we'll see briefly how these 3 new techniques are useful to us in clinical practice. Next one. So when you say volumetric ultrasound, that means you collect a large amount of data from the area of interest and show it in the form of 3D or now, of course, in the form of a 4D. Next please. So we use it extensively in gynecology again. For example, looking at polyps. Next one. And of course, looking at tubal patency. So we use a technique known as hycosy. We put the dye and instead of an X-ray with its potential harmful effects, we can see the tubes as well as the tubal patency. Next one. But the most entertaining is of course looking at babies. So when we look at feti and focus for some time, we can see all sorts of expression. For example, this one is a cool guy, this one is a thinker, this one is already putting his head on the forehead, I don't know why. This one is an angry guy, you know, Albert Pinto ko gussa kyun hota hai. This one is sort of teasing you, and this one is probably sad and, you know, sort of wiping his eyes. Next one. So this is a picture given to me by one of my students. All the three monkeys of Gandhi, Guramat Dekho, Guramat Suno, Guramat Bolo, and he could depict them in feti as he did ultrasound, and then he made this particular picture. He is my student Vishal. Next one. And this one is of course singing loudly, as you can see there. Next one. So this particular aspect of volumetric ultrasound, that means capturing 3D and 4D, we can use not only in obstetrics but also in other areas. For example, doing virtual scopies, for example bladderscopy, looking at inside the gallbladder, almost like doing a scopy of the gallbladder. Next one. And then of course looking at intestines like a laparoscopy. Next one. And looking even in within the uterus like a hysteroscopy. And this is possible because we are able to capture a large amount of data and process it simultaneously and take 4D pictures of the whole thing. Next one. And things are becoming so good, the resolution is becoming so good that probably we can now look, this is a foot of a fetus. Maybe we would have a palmist who would look at a baby's hand and tell us, ye kaun banega, politician banega, what party will go to, etc. And then, you know, what will happen. Next one. So the next revolution was ultrasound contrast. So initially we said that we don't use contrast, but now we do use contrast. But the difference here is that these are bubbles, they are air bubbles or they are gaseous agents, and there is no ionizing radiation. And how they work is that once you inject this in the body, they go all over the body, and once a probe comes and hits that particular area, these bubbles, they sort of vibrate, they generate what are known as harmonic signals, and we see blood flow information many more times than what we would do on a simple color Doppler machine. Next one. And therefore when you have masses like this in liver, which are difficult to differentiate one from the other, we inject contrast. Next one. And yeah, go to the next. Next. Go on clicking. Go on clicking. Yeah. And one more time. So we are able, what look like similar masses. Next one. We can differentiate a hepatoma from a hemangioma, from an abscess, from something benign lesion like an FNH. So with ultrasound contrast, we are now able to characterize lesions more accurately, whether it is liver tumors, whether it is kidney tumors, etc. Next one. And then of course in CRF, where we cannot use CT and MR contrast because they have nephrotoxicity, we can use ultrasound contrast to characterize renal masses as well. Whether it's a mass, next one, or whether it's a cyst, which is complex like this. Next one. And I have been very lucky to be a part of World Federation guidelines for ultrasound contrast use. We have published 2 guidelines which are used extensively all over the world. Next one. This third innovation, as I said, is what is known as elastography. And this is based on hardness of the tissue. And there are 2 types of elastography. One is what is known as strain elastography, which is, you know what the clinicians do, they palpate and say something is hard and something is soft. So instead of using the fingers, next one, we use probes. So with ultrasound probe, we give a gentle compression and we are able to differentiate whether something is hard or something is very soft. Next one. The other technology in elastography is what is known as shear wave. So what are shear waves? So if you have water and if you put a pebble inside the water or a stone, you see these waves which come up, right? So similarly, instead of that, what we do is we use an acoustic pulse and then generate these waves and find out the speed of these waves, and with that we can find out whether something is hard or soft. And this is most extensively used now in the early diagnosis of liver cirrhosis. Next one. So elastography, you can now characterize lesions much better. So yes, for example in breast, this is 100% of breast malignancy because it is very hard on elastography. Next one. Again, we used in prostate, and just before doing a prostate biopsy, we use elastography and find out which part of the prostate one should be doing a biopsy. Next one. The most dreaded disease which is coming all over the world is what? Go to the next one. Yeah, go on clicking. Is what is known as non-alcoholic fatty liver disease or metabolic fatty liver disease. So you will be surprised that even in a country like India, there are some states where almost 40 to 50% of the population has non-alcoholic liver disease. Today, if you go to a school and just wait outside the school, and when when the school is about to leave, just see the build of the children. You will be surprised to see almost 20 to 30% of the children are obese, which is not good. So the whole idea is to pick up fatty liver at a very, very early stage. Why? Because eventually a fatty liver goes into what is known as NASH. Eventually it goes into, I think it has started working. Okay, I don't know. Eventually it goes, let's go. Oh, this has started working. Fantastic. Oh, no. Just go back. Little more. Go back. Go back. Okay. Little one more step. Yeah, that's it. So now you only go forward when I tell you. So what happens is when you have a fatty liver, it goes into what is known as NASH, and then it goes into various stages of fibrosis, and eventually we have cirrhosis. So today we have preventive programs. We want to prevent fatty liver. If it is fatty, we want to pick it up early. We want to treat it before it goes into a stage of fibrosis. And even if it goes into a stage of fibrosis, pick up fibrosis at a very early stage so that it doesn't go into cirrhosis. Because we know that cirrhosis is irreversible and you cannot do anything about it. And this is achieved with the help of ultrasound elastography. Next one. So this is an example of fat quantification. So we have a technique which is known as attenuation, by which you can actually grade the fatty liver, and we can do corrective measures as we know. Next one. And as next one. So this is what is known as shear wave elastography, and this is used to actually pick up early fibrosis in the liver before it goes into a stage of cirrhosis. Next one. So we have quantification techniques. So here, for example, we have figures which are going from 1.8 to 4.8 as the degree of cirrhosis goes on increasing. What we can also do in practice is, some of them are of course alcoholic, is we have this dial, and this dial normally is on this side as you can see, but as the degree of fibrosis and cirrhosis goes on increasing, the dial goes on the other side. So when we tell a patient who is alcoholic and show him, he won't understand the values, kilopascals, etc. So we show him the dial. देखो आज dial इधर है, दारू छोड़ दो, ये dial इधर जाएगा तो कुछ नहीं हो सकेगा. So the whole idea is to pick up fibrosis at a very early stage before the patient becomes cirrhotic. That is the whole idea of doing liver elastography. Next one. So the thing is that we have now so many technologies which are there, and therefore now what we do is integrate all the technologies together, and we call it multi-parametric ultrasound. So for example, this lady has an ovarian mass. So it looks solid on the gray scale. We do elastography, we confirm it is solid. Then we do contrast, and we have a pattern which is typical of ovarian fibroma, just like uterine fibroids, and we give a very confident diagnosis. Not only we say that this patient has an ovarian mass, but we can be very specific and say that this is a benign ovarian fibroma. And this is possible because of the multiple technologies which we use in the same patient. Next one. And we can do interventions. Almost anything in the body we can put in a needle, whether it's a joint or whether it's an abscess or whether it's a lymph node or whatever it be. Next one. The thing is that we can be precise. Now here, for example, this is a patient, there's a very small lymph node here, right? And this is the jugular vein, this is your carotid. So my needle is going here, I can see the tip of the needle, and I'm sure that I'm not going to touch the carotid artery because I'm doing it under vision. So under vision, in real time, I've done an FNAC without touching his carotid artery, which is very close to the lymph node. So we can be very precise when it comes to doing ultrasound guided biopsies or FNACs or whatever you want to do. Next one. And it is fast. Very often, even before the patient realizes what has happened, for example, here we are aspirating ovarian cyst. Even before the patient could realize what it is, we have aspirated the whole thing. So it's real time and it is very, very fast. Next one. And liver abscess is something which we do almost routinely. Next one. Next one. And we can treat liver tumors with radiofrequency ablation, and nowadays even with microwave. Next one. And we can do laser treatment for varicose veins as well. Next one. So again we map the veins and then put in a laser, put in a guide wire and then a laser fiber. Next one. And treat varicose veins also. This is just to show the various intervention techniques which can be done under ultrasound guidance. Next one. And then we do fetal procedures, not only diagnostic, as I said, but also therapeutic. And I'll just show you a few of them. Next one. So the most important diagnostic procedure which we do are amniocentesis and chorion villus sampling. And these are done to pick up various disorders in the fetus, typically genetic abnormalities. Next one. For example, this fetus has what is known as increased nuchal translucency. So what we do now is do a chorion villus sampling and we find out that this fetus has a Down syndrome. So now we can pick up not only Downs, we can pick up any number of genetic disorders, whether they are single gene disorders, DNA disorders, or whether they are something like trisomies at a very, very early stage with this techniques, amniocentesis or a chorion villus sampling. Next one. We can treat a fetus. This mother had hyperthyroidism. So when we scanned the fetus, we found that the fetus has a goiter. So that's the neck of the fetus and the fetus has a goiter. Then we did amniocentesis and found out that the level of thyroxine. We did a thyroid function test on the amniotic fluid as well as the fetal blood. Proved that the fetus is also hypothyroid. And what we did is intra-amniotic we injected thyroxine. So when the baby was born, there was no swelling of the thyroid and mentally absolutely fine. If the baby was born with a goiter with hypothyroidism at birth, that would be a disaster for the child, as we know. Next one. So that's a baby after 1 month, there is no swelling at all. Next one. We can treat fetal anemia. For example, RH incompatibility. What we are doing here, this mother, we are giving fetal anesthesia. So that's a needle going into the fetal thigh. So we are injecting an anesthetist so that the fetus doesn't move during the procedure. Now we are putting a needle in the fetal placenta, in the umbilical cord, in the fetal vein, and then we are transfusing. So we had to give 3 transfusions to this mother. Next one. And the baby was born with normal hemoglobin levels. That's a big thing as far as this baby or the family is concerned. And this, of course, is done for various causes of fetal anemia. Next one. We can treat ectopics. For example, unruptured ectopics, whether they are interstitial, scar pregnancies, whether they are in the adnexal, can be treated under ultrasound guided with methotrexate and potassium chloride as required. Next one. Now very often because of IVF techniques, we land up with multiple pregnancies, though the law says you should do 1. We have triplets, quadruplets, quintuplets, etc. So this is a lady who had 5 pregnancies, and you cannot have 5 pregnancies going to term. Of course there are reports world over, but that's not practical. So what we do in that case, and most commonly when we have triplets, is reduce 1 fetus. So we look at the scan, find out if one of the fetus is smaller or has some anomaly, and then selectively go into that fetus and inject potassium chloride and stop the growth so that the other one goes. Next one. Sometimes what happens is there are twins. So here for example there are twins, one baby is normal and the other baby has gross skeletal dysplasia. Now if you continue with that, the one which is anomalous is going to develop polyhydramnios and is going to hamper the growth of the one fetus which is normal. The same thing happens when the one fetus has acrania or absent skull vault. It is going to develop polyhydramnios. So again what we do is a selective reduction of that fetus under ultrasound guidance, put potassium chloride, stop the growth so that the other baby grows normally. Next one. And so that's what we are doing here. Next one. And at birth, this is the child, baby who was healthy. That's the girl now who was at the age of 3 or 4 years, and that's a macerated fetus which was anomalous. If we had kept it, even this baby would not have seen this day, maybe. Next one. And then we use fusion. That means sometimes we have pictures of MR, we want to correlate with ultrasound. So we use fusion technology where we use CT, MR, put everything together and do a biopsy if required. Next one. And we have now used ultrasound to treat tumors. For example, prostatic cancers or liver cancers are treated by high intensity ultrasound beam, which is known as HIFU. Next one. And the most challenging, most thrilling thing is the use of these micro bubbles, which I talked about for therapy. Next one. So what happens? As I said, that when we inject these micro bubbles, they go all over the body. But when you put an ultrasound beam on the top with the probe, these bubbles oscillate, right, and then generate signals. So not only that, if you put a high intensity ultrasound beam at that particular point, these bubbles will burst, right? So how do we take advantage of that? If you coat these bubbles with chemotherapeutic agents or any agents which are going to help the patient, inject them systematically into the systemic circulation, and then focus on only one part where the tumor is, for example in the liver. Next one, these bubbles will deliver drug only at that point, and the rest of the body, the drugs will not be delivered because the bubbles are not going to rupture. Which means that by avoiding the systemic effects of chemotherapeutic agents, we'll be able to treat tumors. And this is already started in animal practice, and it will soon come up in human practice. So that's a big thing which will come up in future. Next one. And of course now this is an old dissection hall, and eventually of course teachers will start teaching using imaging tools. Next one. And of course she talked of AI, and AI is everywhere. We have to accept it. Next one. So similarly in ultrasound, next one. We have AI everywhere. Next one. Next. In fetus, for example, right from diagnosis to picking up predicting birth disorders, growth disorders, to predicting the time of delivery, everything can be done with AI. Next one. We can map fibroids now with AI most accurately. Next one. This in IVF, when you do an in vitro fertilization, you have to know whether the endometrium is good. So we have various parameters. So we put in a probe, we get all the parameters, and the robot comes on the screen and says, okay, this endometrium is receptive, you should implant the blastocyst now, or this is not receptive, you should wait and watch. Okay, next one. And ultrasound machines are already in the space. Most of the US spacecrafts have an ultrasound machine where they use it for diagnosing things in the astronaut or conducting some experiments. Next one. And of course all these technological advancements translate into, next one, better treatment for the mankind. Next one. So I would like to end with the fact that ultrasound in India is at a very high level, and we are going to host the World Federation of Ultrasound meet in the year 2029. By then, those of you who are budding physicians would have already passed out, and I urge you to sort of come to this event. And I hope that at least few of you would have got stimulated now to take up radiology, and more specifically take up the field of ultrasound. Thank you so much.
I would like to extend my warmest gratitude to Dr. Nitin Chaubal for concluding Day 1 CPD conference. Your knowledge and clinical insight will motivate our students to develop clinical acumen and embrace curiosity in their MBBS journey. Thank you, sir.